Hi, can you hear me? So again, I want to thank the Voice of God for the introduction. I was asked that we repeat one announcement over and over again, and so you heard it from Patrick a moment ago. Of course, this is our 20th conference, and I've been asked to remind all of you to tweet hashtag HA20, and hopefully you will do that so that we celebrate accordingly, appropriately, that this is the 20th anniversary of our Health Reform Conference. Now, I have to say, one of the nice things about working at Families USA these days is that we give out prizes periodically to people on the staff for some of the good things that they do. And these prizes are like tchotchkes, if those of you know the word tchotchkes. Includes things like movie tickets, food, lunches, gift cards, and the big is a prize to attend a major conference in the course of next year in San Francisco. And so my hope is that some on the staff will actually give me a prize on Monday to celebrate that an award that is kind of unprecedented, the Glutton for Punishment Award for speaking after Elizabeth Warren. So I want to talk to you today about where we are as a movement to achieve high quality, affordable health coverage and care for everybody, and where Health Reform 2.0, that's in your bags that you have picked up when you registered, where that fits. Now, I gave a talk about this yesterday, the pre-conference. This is going to be different because I don't want a bunch of people snoring during my talk. So I want to talk about this from a little different angle and talk about it more from the heart. And to begin with, it's important for us to underscore that this week we celebrated something very significant. We commemorated, as a nation, the 86th birthday of the Reverend Dr. Martin Luther King. And there are many lessons that we can learn from him and the civil rights movement that he helped to lead as we think about our present and future efforts to secure high-quality, affordable health coverage and care for everybody. And one of the lessons that I want to focus on was the lesson of what the movement under Dr. King's leadership did soon after the passage of the Civil Rights Act of 1964. The Civil Rights Act of 1964, perhaps with the exception of Brown v. Board of Education, decided unanimously by the Supreme Court 10 years earlier, was the most significant change in civil rights since Reconstruction, about a century prior to that. And the 1964 Civil Rights Act had very significant provisions that our nation could celebrate. It outlawed discrimination in public accommodations, in hotels, motels, restaurants, theaters, and retail stores. It enabled the government to join in lawsuits against state governments that operated segregated school systems. Brown v. Board of Education said that should be fixed, and the words that they used, with all deliberate speed, and quite the opposite occurred. This gave new tools to actually achieve greater speed. And the Civil Rights Act of 1964 did something else that was very important. In Title VII of the Civil Rights Act, it outlawed employment discrimination by any employer who had 15 or more workers. This was a monumental achievement, and it was an achievement that was won by the movement with blood, sweat, and tears. But shortly thereafter, Dr. King began a campaign pushing for the Voting Rights Act, which for some of you who have already had the chance to see the movie is depicted in the movie Selma. He noted that meaningful opportunities to vote, without having that, African Americans would be powerless to secure political change. And he said something also that was very significant. He said that without the right to vote, without people registered to vote, it meant that African Americans generally, and civil rights workers specifically, could not stop violence that was rampant throughout the civil rights movement. And the reason it couldn't stop violence is because you had all-white juries in states across the country. Because in order to be on a jury, you had to have been registered to vote. And if you hadn't registered to vote, or you were stopped from registering for voting, then you couldn't be on a jury. And so as violence occurred throughout the civil rights movement, you didn't even see prosecutions brought, because you'd never get a conviction by an all-white jury of a white person who beat up African Americans and civil rights workers. And I have to say, for me personally, this is very personal, because Andy Goodman, a classmate of mine, Mickey Schwerner, the brother of a faculty member at our school, and James Chaney were brutally murdered in Neshoba County, Mississippi. And interestingly enough, it occurred 11 days before President Johnson signed the Civil Rights Act of 1964. And everybody knew that the state of Mississippi was not going to prosecute the people who killed Goodman, Schwerner, and Chaney, even though we knew who killed them. It was Deputy Sheriff Cecil Price. It was Sheriff Lawrence Rainey. It was Sam Bowers, the Grand Imperial Wizard of the Ku Klux Klan. But there was no way the state of Mississippi was going to prosecute folks for murder. Their bodies weren't found until weeks thereafter. So quickly, on the heels of the passage of the Civil Rights Act of 1964, Dr. King started a new campaign for voting rights. And the lesson we learn from Dr. King that we all should take and keep in our memory is that in social movements, there's no such thing as final victories, and there's no such thing as final defeats. And in the words of the movement, our job is to keep on keeping on. That is our message, and that's what we have to do in the months and years ahead. Well, how does this apply to the work that all of us are doing with respect to health care and trying to achieve high quality, affordable health coverage and care for everybody? Well, we just passed historic legislation in 2010, and it is truly historic legislation. There are many different provisions in the Affordable Care Act that was signed in 2010, but the way I try to capsulize what makes the Affordable Care Act such a historic piece of legislation is that for the first time in our nation's history, health coverage became a right, a legal right, for everybody lawfully in the country. Now, this is truly a remarkable achievement, and all of you who have been working for years to secure that victory can be very proud of what you have accomplished. But one of the things all of us know about landmark legislation, whether it's a civil rights law or whether it's a law relative to health care, is that a legal right is not the same thing as a living reality. And our job, the job in front of us, is to take that precious legal right and to make it a living reality. We have very far to go. We've gained health coverage, as Senator Warren said, as the President said 2 nights ago, 10 million uninsured people gained health coverage. It's a marvelous achievement. But the Congressional Budget Office tells us that in the year 2022, there will still be 31 million people in our country who will be uninsured. Is our work done? Of course not. More than 1 out of 4 uninsured people secured coverage during the first open enrollment period. That's an extraordinary accomplishment. It's something we can all take pride in. But for a lot of people who have gained coverage, the deductibles that they have to pay in order to get care are extraordinarily high, and for too many people, they're unaffordable. And so they have an insurance card, but they may not have care. Is our work done? Of course not. One of the benefits in the Affordable Care Act, that's a required benefit, is the provision of pediatric oral health care. It is now a required benefit. Those of you who work in this field know here there's a real difference, again, about a legal right and a living reality. But what we know is that among adults, more than 1 out of 4 people do not have any dental coverage. And one of the things that I hope some of you get to see during the conference on Friday evening, there's going to be a movie called Remote Area Medical. It's about a free charitable health clinic in Rockford, Tennessee. And one of the things you learn about what happened in Rockford and what happens in free charitable clinics all across the country is that the #1 service that people coming to these charitable health fairs ask for is to have their teeth extracted. And to have their teeth extracted because they didn't have dental care, and as a result, they have had tremendous decay, and they needed to have their teeth pulled. Is our work done? Of course not. In communities of color, by the end of the second open enrollment period, millions of people will have gained coverage, and we should rejoice about that. That is extraordinary. But due to shortages of primary care doctors, especially doctors who provide language-accessible, culturally competent care, too many people are not getting care even though they have coverage. Is our work done? Of course not. So that's why we at Families USA, on Monday, the day that we celebrated Martin Luther King's birthday, we released our vision for what we should do in the future that we called Health Reform 2.0, because we understand that for all of us who've been working in this cause, the quest for high-quality, affordable health coverage and care for everyone, it didn't start with the Affordable Care Act, and it shouldn't end with the Affordable Care Act. We have lots of work to do. Now, I am reminded yesterday, John McDonough gave a talk relative to a piece of legislation that many of us savor. It reminds me of a story that I experienced the week before the vote in the House of Representatives on the Affordable Care Act. I was walking to Speaker Pelosi's office. There were numerous meetings because we didn't have the 218 votes we needed to pass the Affordable Care Act on the floor of the House, and we were planning different things that needed to be done to gather those last votes. And as I was walking towards the Speaker's office, out walked a wonderful congressman. Many of you know him, Raul Grijalva from Arizona. He's the co-chair of the Congressional Progressive Caucus. And I had read a lot of the comments that Congressman Grijalva had said about the Affordable Care Act and all its inadequacies, all the things that should have been done that were not included in the legislation. And as we were passing one another, I said, Raul, how are you going to vote next week? And he gave me a litany of all the complaints, all of the inadequacies of the Affordable Care Act. And I listened at the end of his description of all the things he thought was inadequate. I said, Raul, I agree with every single thing you just said. How are you going to vote next week? And he started again. I said, wait a minute. If I asked you, as a leader of progressives in the United States Congress, what are the half-dozen pieces of legislation in the history of our country that you savor? And could I suppose that one of those half-dozen pieces of legislation was the Social Security Act of 1935? And he said, of course, absolutely. And I said, Raul, what do you remember of the 1935 Social Security Act? By the way, for those of you who see my gray hair, I was not alive at the time. I know, that's causing disbelief among some of you. And Raul said, you know, I don't remember much about the Social Security Act of 1935. And I said, well, what if I told you that the Social Security Act of 1935 failed to cover over half the women in the workforce from its protections? And what if I told you that the Social Security Act of 1935 failed to protect over 2/3 of the people of color in the workforce? Now what do you say about it? And he stumbled. I said, don't answer that question. You were right. We should rejoice at the passage of the Social Security Act of 1935. We fixed those things. And we fixed it as a nation. I wasn't around. The Social Security Act of 1935 gave us a platform. It gave us a foundation upon which to build. And that's the way we should look at the Affordable Care Act. It is not perfect. There are so many imperfections, notwithstanding the fact that we rejoice at its passage and should rejoice at its passage. It provides a foundation. It provides a platform. And our job is to build on that foundation and to build that platform in such a way that we truly do achieve high-quality, affordable health coverage and care for everybody. Now, all of us in this room are cognizant of the context in which we live today and what happened this past November. There are now 54 Republicans in the United States Senate. There are now 247 Republicans in the House of Representatives. There are 31 Republican governors in state houses across the country. And state legislatures in 37 states, Republicans control at least one chamber of the state legislature. Now, I don't want to talk in a partisan fashion, and we are all nonpartisan organizations. We really are. You saw the picture of Chuck Grassley coming to one of our conferences. But we can't fail to recognize that the Affordable Care Act has had too many partisan overtones. Not a single Republican in the United States Congress voted to support the Affordable Care Act. And every Republican in the Senate and the House ran on a platform to eviscerate the Affordable Care Act. And so it's not surprising that we are facing threat after threat after threat that we will be confronting in the months ahead and in actually the next couple of years ahead. Tops on that list in my book is King v. Burwell. King v. Burwell, by the way, mark this down if you don't know it, is going to be argued in the Supreme Court on March 4th. And a decision is going to be rendered in June. And the reason I ask you to keep that in your mind is that those of you who work in states that are federally facilitated marketplace states, that the people in that state are at risk of losing their premium subsidies and would rejoin the ranks of the uninsured, and too many of those people with chronic health conditions could face the ultimate problem, even death, certainly risk of their lives, of their health. And so to the extent you've got people in your story banks or who you know, particularly those who are fairly close by, come to the court on the morning of March 4th, because we want to make sure what's so absurd about that lawsuit, aside from the merits of the case, is that there are two parties to that lawsuit. There are those who are opponents of the Affordable Care Act, and there's the government. But the people who are at risk in that litigation are not parties to that lawsuit. They could pay the ultimate price. And so one of the things we do as a movement and need to do in the weeks ahead is to remind people what is at stake here, so that no justice fails to understand what they are doing if they rule with the petitioners. So March 4th, to the extent you have people you know who are in the situation, we're flying in dozens of people for the Supreme Court argument. Join us. But that's not the only threat. There are going to be serial efforts to undermine, to repeal all or part of the legislation in Congress. And of course, we still have the ongoing foot dragging in state after state, with 23 states that have refused to implement the Medicaid expansion even though the federal government is picking up 100% of the cost. It's outrageous. Well, one of the things I did say yesterday is that in social movements and in politics, and actually in baseball as well, you're either pitching or you're catching. And we've been doing a lot of catching since 2010. And as part of our work, we still have to do some catching, but we've got to do some pitching as well. And that's why we have offered Health Reform 2.0, so we have a vision about how we want to move forward. We have a vision about how to perfect the imperfections that exist in current law. Now, I'm not going to go over, time does not permit to go over the 19 proposals in Health Reform 2.0. Suffice it to say, it's in the bags that you received when you registered. But our 19 proposals have 4 key objectives. Number 1, secure health coverage for all. Number 2, ensure that health coverage means access to needed care. Number 3, transform our health care system to provide care that is appropriate, highest in quality, equitable, and patient-centered. And number 4, to reduce health care costs and make care much more affordable. Now, I've got to say, integral to every one of those 4 goals is for all of us to commit to achieving language-accessible, culturally competent care throughout the healthcare system and to eliminate healthcare disparities in the most vulnerable communities. We are committed to doing that. You will note that our 4 goals, 2 of the goals relate to coverage and getting care. 2 of them relate to health system transformation. This is actually my segue to our next wonderful speaker. What I mean by health system transformation, I mean the confluence of quality of care and health care costs. And it is important for us as we think about the future, it's important for us as consumer organization leaders not simply to engage in this work. It is critical that we lead this work. And the reason we need to lead this work as consumers, there are 4 reasons. Number 1, if we keep on having higher and higher and higher costs, what does it do to our wages? It means we're suppressing wages. And one of the conversations we're going to have in the political context this year and the years ahead will be what's happening to wages. Secondly, if we don't deal with costs, it's going to crowd out some of the things that we hold dear, like education for our children. Number 3, high costs place pressure on the public programs that we depend on, that are the safety net, programs like Medicaid and Medicare. So if we don't deal with costs, we're going to see constant efforts to cut those programs. And the last one is the easiest. If we don't see relief with respect to costs, premiums are going to rise, deductibles are going to rise, and so actually having coverage and care will be in jeopardy. So our work, it's going to take a while to accomplish. It won't happen overnight. It will take years, but we have to start. We need to plant the seeds so that everyone has the care they need, when they need it, and at an affordable price. So that leads me to the wonderful task of introducing our next speaker, who is going to focus on health system transformation. Our next speaker is a longstanding friend. Again, I won't call him an old friend. He's a longstanding friend, Dr. Reed Tuckson. Reed was the Commissioner of Public Health for the District of Columbia. He was the president of the Charles Drew University of Medicine and Science. He was senior vice president of the March of Dimes. He was senior vice president for professional standards at the American Medical Association. And he was a vice president, executive vice president, and chief of medical affairs, United Health Group. Reed has been one of the leaders on health system transformation. He's going to talk about the context of our tasks ahead with respect to health system transformation. But if I know Reed, he's actually probably going to put a collar on and he's going to do a bit of preaching. So please welcome a good friend, Dr. Reed Tuckson.
Thank you, thank you, thank you. I am so privileged to be with you. And I'm so glad to hear that you've still got fire in the belly, that you've still got energy, because there's a lot of work to be done. I've been at this for 45 years, fighting for universal access to health care for all Americans and to make sure that people get the care that they need. And I'll tell you this, I ain't no ways tired. Ain't no ways tired. But I will tell you that we've got a lot of work. And I couldn't help but take the challenge that Ron gave me that says, look, we are trying at Families USA to think about these issues in a new way, and that there's expanding of your portfolio. If you care about expanding access, then you have to deal with the issue of rising costs. I'll come back to that. You have to deal with the issue of inadequate and suboptimal quality. You have to get at that. And third, we have got to get at this problem of prevention. I love this slide. We get all freaked out by Ebola while we're eating a hamburger and smoking. It's just insane. The prevention problem is absolutely fundamental for us. That's the context of our work. There is relentless change across the continuum of healthcare today. Insatiable innovation in care delivery, insatiable innovation in how we finance and organize care services, in the evaluation of the performance of the delivery system, in managing medical costs, in consumer engagement, and in benefit design. All of these ultimately are now falling to you to have a voice in, if you really, really care about being successful with expanding access. All of those three things lead to the one common theology that every stakeholder in healthcare today can get their arms around. No matter who you are, whatever your role is in health, it's the triple aim. Everybody has accepted this as the theology. The picture of Don Berwick there, who had so much to do with it. Improving the health of the population, enhancing the patient experience with care, quality access and reliability, and then, as Ron has indicated, reducing the costs of care. This cost escalation is absolutely frightening and determinate. There is no major employer in America today that is not terrified of the escalation in their healthcare costs, and they refuse to write any more checks for increasing premium. Every small business owner in America today is terrified of the escalation in healthcare costs, and they are absolutely clear, no more exposure. That leaves you with, as you go to the Medicare system, you know and I know how challenging it would ever be to get a tax increase sufficient to cover the escalations in Medicare expenditures. It is going to be almost impossible to happen. You can't get any more money out of the Medicare system, even though we are facing this coming issue once again of how much we're going to pay providers and hospitals. That leaves you with the states to get money. Well, does anybody really believe that we're going to enhance Medicaid expenditure at the state level? It can't happen. And so this slide originally was the bending the curve slide, the bending the cost curve slide that was done way back when President Bush, the younger, was in office. And Bush was all talking about Social Security, Ron. And he said, Social Security, and I wish I could do the Texas twang, but, you know, ladies and gentlemen, we got a Social Security problem here in America. Best I can do. I'm in Atlanta now. And his budget office said, look here, dude. Well, actually, I don't think they call the president dude. Probably, Mr. President, sir, you don't have a Social Security problem. You got a Medicaid and Medicare problem. And so the effort, of course, has been, how do you call it, been that cost curve. And Ron, you're absolutely right. This is what happens at the state level. This is the expenditure increasing on health care, and the curve that's going down is for, actually, it's a different one, but this is the expenditure. But if you look at it at the state level, the direct opposite of the health care curve is the decrease in K through 12 education. We are mortgaging our kids' education for the future based on how much we are spending on health care at the state level. So if you can't get any more money out of the biggest employers, especially those that are globally competitive, you can't get any more money out of small employers, if you can't get any more money out of the state, you can't get any more money out of the feds, where do you get it? Mrs. Jones at Fifth and Vine, your people, the people you are so legitimately and passionately concerned about. And Ron, you're absolutely right. I said it's a different way to make the point you made. On the green, the upward is the escalation in out-of-pocket health care expenditures for the average American, and the bottom slide is wages. Does anybody really think, even with legislation, that wage curve is going to go up and compensate for that delta? What people don't understand today in the healthcare debate is that increasingly the decisions are being made around money that is in Mrs. Jones's pocket, not some faceless company that's a big corporation or insurance company or someplace else. This is very personal now to the American people, and this is why it is so important that you're attentive. We have $750 billion in waste in healthcare today. Where does it come from? 27% of it, $210 billion, from unnecessary services. Inefficiently delivered services, 17%, somewhere around $130 billion. Prices that are too high, $105 billion. Excessive administrative costs, $191 billion. Fraud, and then missed prevention opportunities. Each one of these are areas that we have to work on together. Underneath this cost escalation, the biggest component of cost escalation in healthcare is unit costs, the price of things. And so what you have now are hospitals and outpatient clinics, and now you're seeing movement to bring outpatient stuff inside of the delivery system, driving up even more costs on the negotiating. So we're seeing lots of consolidation around hospitals and big delivery systems who are then fighting very hard to drive up their unit costs. And the negotiating around all of that is key. The point being, you at Families USA are going to need to be very attentive to the fights over prices and be thinking about what your role is in having something to say. But this is key for your consumers. There is extraordinary variation in episode costs within the Medicaid program, a 250% difference in Medicare spending across the nation, and very much different even in private insurance plans. Wide variation in the costs of things that don't make a lot of sense. And please be aware, there is no, I got to emphasize this point. Somebody wants me to make sure you understand. There is no relationship between spending more and getting better quality. This is a fundamental issue that has to be understood. This is just an example of that variation. This is for cardiac catheterization, and the horizontal axis is quality, and on the bottom, on vertical is quality, on the horizontal is the cost. It is a complete scattergram. It makes no sense whatsoever. So how does your constituency, average consumer, make choices and decisions inside of that? I'll come back. You should be aware that according to the American College of Internal Medicine, the American Board of Internal Medicine, they now are telling us that 30% of care delivered in the United States is duplicative or unnecessary. There are more than 130 tests and procedures that are commonly ordered, but are not necessary. And so we've got this enormous opportunity to be attentive to quality. But it is going to get worse and more complex. Senator Warren told us about the importance of NIH. I serve on the advisory committee to the head of NIH. I spend a lot of energy on NIH. I got an advocacy award recently from Research America. I was very pleased because I'm a fighter for the budget of NIH. I love basic science. But you cannot stop with advocacy for NIH. Here's why. This is the genomic world. On the right side, going vertically, as you increase our knowledge and sophistication of genetics, on the left side, you see the number of facts per decision increases geometrically, and you see the curve going up. What is not changing is human cognitive capability. Now, unless y'all got some special kind of fish oil or something like that, right, we got real issues. We're not any smarter than we were before. Ladies and gentlemen, who is going to educate the American consumer to make statistical probability decisions with their healthcare provider in a genomic era? You see the complexity. And then we've got new drugs. The product of innovation, which Senator Warren was correct to trumpet. But guess what? Here's a drug for hepatitis C. It's a terrific drug. Guess what? It works. However, it's $100,000. And it is not the only drug in the pipeline. The biggest drugs that are coming down the road are these specialty pharma drugs, which are very complex. And they are hugely expensive. And somebody is going to have to make a decision. Who gets access to those drugs and under what conditions? Conversely, who doesn't? Can everybody have everything all the time? Who makes those choices? I love being with you because you need to be a voice in that conversation. Who are the people that got hepatitis C in large numbers who need that drug? A bunch of them are people who have IV drug abuse, poor people, people on the margins. So my big third issue, prevention. This is a cool slide. Watch this. This is unbelievable. I love this slide. We have a tsunami of preventable chronic illness washing over a delivery system that we cannot afford. Make sure you understand what I'm saying. The prevalence of preventable chronic illness is skyrocketing. We now know that still, with the advancements that we've made, still 20% of the American people smoke tobacco. 450,000 people are going to die this year. Inactivity, 23% of the American people are inactive. 8% obese. Diabetes, almost 10%. Do you understand what this means? There are a gazillion people who are going to be really sick and who don't need to be sick. And guess what? They're going to live forever. Because we have a terrific medical care system. It works. We will live long lives with unnecessary illness. Guess what? You can't afford it. You cannot medicalize your way out of a preventive problem like we have. I'm sorry to put this on your agenda, Families USA, but the fight for prevention is yours. If you don't fight it, you can't win the access issue. You can't sustain it. And then finally, because you're going to live forever, you're going to need a lot of medical and non-medical social support services to be able to sustain you because you're living with all of these chronic illnesses. I'm going to come back to that as the very last slide. So, what are we trying to achieve? I wish everybody would write down in your notes, crossing the quality chasm. I would beg you, read it again. It's old. Why is Dr. Tuckson asking me to read something that was out in 2001? Because it is still the best blueprint for what you are fighting for. And I urge you to read it. This is where the mantra comes from. The care should be safe, effective, timely, efficient, equitable, and patient-centered. This is the theology. It says you should insist, you at Families USA should fight the health care to be based on the best scientific evidence. You should make sure that safety is a system property, that we are continually decreasing waste, that there is, oh my God, a revolutionary thought, cooperation among clinicians. You want to fight that the you should be anticipating the patient's needs, that the patient should be the source of control, that care should be based on continuous healing relationships, and, Ron, if you want to talk about equity, customization based on the patient's needs and what? Values, respecting the dignity of each individual. And lastly, it should be based ultimately upon shared knowledge and free flow of information. This is key. My first take home for you. It's important that you be attentive to facilitating the ability to aggregate data and share it interoperably across providers of care. It has to happen. Great new excitement is happening in this space. We're now able to take medical claims, laboratory pharmacy data, health risk assessments, screening data, electronic medical record, health information exchange data, biometry data, home health care apps, coaching. There are very weird people in this world who have made it their life's work to take these strange databases and stick them together, analyze them, liquefy them, and make them available for decisions by patients and by the medical care system. This is very hard work. Here's the rub. People, of course, are legitimately terrified that people will hack into this information. And we may find that there will be a lot of people who will say, slow down on the data sharing, dude, because somebody may hack. So we have got to fight for cybersecurity for healthcare. We've got to fight to make sure that we are protecting sensitive information. But above all, we need information to flow so that we can take care of people appropriately. It's important for you to be attentive to facilitating appropriate security protections for health data. That data then goes into the delivery system, which is currently fragmented. These people don't talk to each other. The hospital, the individual medical care doctor, the pharmacy, the public health people, they are all siloed. We have to be able to have information pull up together, analyze the information, and then drop it, liquefy it, so that when you come into your doctor's office, your doctor is prepared with information, or what we call actionable intelligence. What that means is that there is an alert that says, hey, Mary Smith is coming in. You, doctor, need to know they've got a strange genetic thing, and the number of facts per decision is more than your human cognitive capability, but we don't want you to kill her. So guess what? An alert comes up and says, this is what you need to do. Remember Marcus Welby? Wouldn't make it a day in this world because it's too much stuff to know. Marcus needs a computer. All right. Information that tells them where are they wasting money for Mrs. Jones on 5th and Vine? When are they pissing away Mrs. Jones' hard-earned contributions? Why did you order that test for Mrs. Jones? You shouldn't have done it. Or why did you send Mrs. Jones for that CAT scan to the most expensive place in the universe, which has the worst quality, instead of sending her to the best quality and the most cost-effective? It's coming in large measure out of her pocket. You got to treat her right. So we got to have data and information that allows you to be able to do that. We have real problems with advancing the electronic medical records and health information technology. Every time we try to get real electronic health record progress, the forces of stagnation always say, we're not ready. Somebody ate my homework. The dog ate my homework. I can't do it. And you know who writes those letters? 250 congresspeople at the behest of those that do not want to change. You need to be attentive, ladies and gentlemen, very much to make sure we have an interconnected and interoperable IT system, systems that can talk to each other anywhere, anytime with access to information. You are happy to go to your ATM machine for your banking account. You're happy to go to Europe and stick your card in from the United States and they will give you money. Why does that work for banking and you can't do it for your health information? It doesn't make any sense. Why are we so slow? We have to overcome brand-specific things. Our computer electronic record only speaks to ours, and we will not talk to yours. Well, then you should be out of business. You should be out of business. Advance the evolution. To be able to get this done, there's got to be financial incentives. We need government and delivery system to help out, and then we've got to make it easy for the docs to be able to do. At the end of the day, I want you to be particularly attentive to an office that you may not look at. It's called the Office of the National Coordinator for Health Information Technology. That's where the letters are written that say, slow down on electronic medical records and getting it done. Would you please add ONC to your list of things to care about? It's very important. And then make sure that you are paying attention to something called the Blue Button Initiative, which is the government's strategy, which I really like, and it's very important. It's a public-private partnership to try to get people to be able to have access to their own personal information. Very important. Therefore, I want you to be attentive to the Office of the National Coordinator and the Blue Button Initiative. I want you to take data and information about what's happening in terms of the prevention of disease initiatives in your environment. This is something that I do called the America's Health Rankings. We've been doing it now for 25 years. We love it. There's a Robert Wood Johnson initiative that does it at the county level. We do it at the state level. There are others. The Commonwealth Fund does it. My point is this. If you are a true Families USA advocate, you will know the data for where you live, what is killing the people in your environment, and then you will work with your community to organize the assets for strategic planning to overcome it. It is so important that we bond together. You can't win this prevention fight acting one by one by one. We need communities engaged. You are great at organizing, and so we need you to make prevention a higher priority and engage your community in local health planning based on data. We need to move the delivery system on a journey from providing care to managing health. This is a fundamental reorganization of how we think about health care. And again, it comes back to data, because what the delivery system is caring about is when you're half dead. We want you to care early and say, you know what, Mrs. Jones, I think you're starting to get sick. Come on in, Mrs. Jones, come on in. I want to see you, because I want to prevent you from going from almost sick to damn near dead. And I got to intervene. And that requires data and information, but it also requires a change in the delivery system, reimbursement. I think most of you are sophisticated enough to know we are moving off of this fee-for-service system to a more accountable, value-based delivery system. If you only pay doctors and hospitals to perform piecework, they will give you piecework. We are now moving towards saying, I'm going to pay you for the value that you deliver, and that's what's going to be the most important. So these are just fancy ways of saying we're going away from fee-for-service towards basically back to what's capitation again. This is another way of saying, just a very busy slide, that all it is trying to point out to you is that single solo doctors are going to be dinosaurs if they're not already. We're going to be moving to much larger groups of clinicians on the horizontal, and on the vertical, we're going to be paying you in much different ways, but getting off the fee-for-service system. And these red stars are just indicating that there'll be multiple models for this all over the country. There's no one size that fits all. Every community is going to be different. So you, as Families USA advocates, need to be attentive to it, not only as national policy, but what I am urging you is to be attentive locally where you are. The delivery system is being assiduously evaluated now based on the quality of care and the cost effectiveness. Now, I'm going to say something that you're not going to like, because I know it is a controversial issue in some political circles. But the reality is, in addition to evaluating the quality and cost effectiveness and letting people know, you will see healthcare benefits increasingly aligned with a narrower network of a sweet spot of high performers. And that's actually I have 7 minutes left. She tried to tell me I only had 5. You got to watch these timekeepers. High-performing network, very, very important, because people are going to be, there's going to be a lot of incentive to say to the delivery system, if you suck, you shouldn't be in the network. You have to show that you're doing right. And so we're seeing, and you should put down this name, Catalyst for Payment Reform. If you want to learn about what's going on in the reimbursement system, Catalysts for Payment Reform are good folk trustworthy, and they're telling you what, they'll teach you what you need to know. But you need to be attentive to advancing value-based reimbursement that aligns quality with cost. And there needs to be transparency. Remember the slide I showed of the cardiac catheterization where it's all over the place? How does a person, a consumer, know what's going on? Well, there needs to be metrics and information, cost calculators, that will tell you what you need to know so you can make an intelligent decision, not only about quality, but also about cost. So we now have new value-based health benefits, where the benefits are being given to people, or sold to people, that says you need to have skin in the game, just like the doc. And now the push is aligning value-based reimbursement with value-based benefits. But if that's going to work, you have to be able to have some information about cost. Well, now the major insurers are coming together, and they're providing that information together. So now you have companies that are doing healthcare cost estimators that will tell you exactly the cost for individual providers of care in local markets with their real prices. And now you can see, first, the quality of the doctor. Does the doctor suck or not? Because you could care less about price if you don't know whether the doctor's any good, right? Don't ever fall for going to the cheapest doctor. Best doctor, then you look at price. Now you can see what the price of the doc is and compare them to the other people, and now start to make decisions. So it's important for you to demand price transparency. And this is the hard part. How do you teach your constituents how to use that information and make choices? To whom does this task fall? So I am asking you to consider strongly being teachers, so that when you are trying to guarantee access, you are making sure that people are not wasting their money on crappy decisions because somebody's hospital was in U.S. News and World Reports, which means nothing, has nothing to do with quality. And you want to give people the information so they make right choices. And then finally, you really need to ensure that people are prepared and engaged to pursue this. And there are wonderful new tools now around helping people to be better consumers of engagement. We are now having our data that tells us who we ought to talk to. We know what we need to talk to them about. Hey, Ms. Jones, your hemoglobin numbers look pretty bad, or your diabetes numbers look pretty bad. We got to get at you. But here's where the breakthrough is in the modern reorganization of delivery system. How do you talk to doctors? I was introduced as the former doc for the AMA. We love this theory and theology of the patient-physician relationship. I was responsible for carrying that flag all over America, and I'm proud to have done it, and I'm proud to do it. I give commencement at medical schools all across the country every year, and I retake the Hippocratic Oath all the time. The sanctity of the patient-physician relationship is key. But guess what? Doctors are not really that good at talking to patients. Not like Amazon is. They aren't as good as iTunes is. iTunes loves me. They know me inside and out. They always want me to do something with them and tell me about people that are like me. My point is this. There are new tools that are being brought to us that allow us to reach consumers in innovative, exciting ways. So wireless and broadband technologies with all the social, do you know your social network is probably more important to changing your health behavior than the geographical neighborhood in which you live? We're just learning that. Social networks, key. You got to be engaged with that. It looks silly. Guess what that selfie is? That phone is a terrific transmitter of information to connect people to the delivery system in convenient, cost-effective ways. Terrific, and it works very well. Innovation all over the place. Sensor data and data is now the largest source of data in the world. The largest source of data in the world is sensor data, and we're using it in healthcare like crazy. Blood pressure monitoring, your Fitbits, all of this kind of stuff, transformative opportunities. And then gaming technology. Children, you get a dose of exercise or else. Or, hey kid, go play Xbox Connect with your family. I just did a study. Your heart rate goes up just as much as if you got a dose of exercise. gaming technology. We have so many new tools at our disposal. And so here's the issue. As all of these new tools swirl around us, in the modern context, Families USA, the question ultimately becomes, and the really operative thing is, how does all of this change to human cognition? How do you actually use it to change behavior? I would urge you to be a part of the movement of how to think about reaching people and changing. I don't have time to do this. I wish I did. You would love this slide. Keep you tantalized. Maybe I can come back another one. And my last slide is that. It is important for you to be attentive to technology evaluation. Let me just say this to you. I remember the political conversation that happened when they started to think about evaluating technologies and what works and what doesn't work. And somehow or another, the conversation by some of the political people was that you're talking about killing grandma because you have no right to look at cost when evaluating technology. And that the pernicious, mean-spirited people somehow would say that Mrs. Jones shouldn't get something because it costs too much. And so we are prohibited in this country from looking at cost when we evaluate new technologies. Well, folks, I'm gonna tell you something. You got a tremendous train of new stuff rolling down the track. Somebody has got to make some decisions about who gets what and when, because there ain't no more money. You can't just, there's nowhere to get it. Decisions have to be made. And what I'm saying to you is, you need to be very attentive to this issue of how those decisions and choices are made. And America right now does not have a legitimate back fence to have that conversation. You at Families USA can be hugely important in doing that. Well, I just want to thank you. I knew that I was going to be in trouble by putting so much on your plate because y'all are already worn down and got a lot to do. But ladies and gentlemen, I think that when Ron and I sat down and spent a lot of time getting into this, it is not possible to be advocates for expanding access if we do not solve for the quality and cost-effective equation. There just is no way for the math to work. So 2.0 health reform means getting outside of your comfort zone and being in some new places. I can't think of better people to take this fight on. Thank you. Okay, is that all right?
That was actually terrific.
Okay, thank you.
Okay. You know what I forgot to mention about Reed? He didn't go to medical school. He went to divinity school so he could be a preacher. So we were thrilled. Thanks so much, Reed. Patrick, you've got some announcements?
All right. So we're running right on schedule. So immediately go to workshops because that's the next thing. We have the workshops are going to begin right now, and there will be no break since everybody's just gotten through eating. You'll go to your workshops, come back here at, those will finish up at 3:30, and then we'll be back in the room here at 3:45. Keep up the hashtagging and the tweeting. We're seeing a lot of stuff out there. And obviously social networks are going to determine your health going forward. Thank you.